नहीं सर, आयुषी लिंक पे आज तक ECT की। Morning everyone. Today we have a group discussion on cluster C personality disorder. It will be presented by me. The moderator for this is Dr. Sanjeevi. What is personality? Personality refers to all the characteristics that adapt in a unique way to the ever-changing internal and the external environment. Personality disorders symptoms are egosyntonic, that is, they're acceptable to the ego, and alloplastic, that is, adapt by trying to alert the external environment rather than themselves. The fifth edition of DSM defines general personality disorder as an enduring pattern of behavior and inner experience that deviates significantly from the individual's cultural standard, is rigidly pervasive, has an onset in adolescent or early adulthood, is stable throughout time, leads to unhappiness and impairment, and manifested in at least two of the following four areas, that is cognition, effectivity, intrapersonal function, and impulse control. The DSM-5 organizes DSM-5 organizes 10 personality disorder into 3 groups or clusters based on the shared key features, that is cluster A, cluster B, and cluster C. Cluster A is odd and aloof features, including schizotypal, schizoid, and paranoid personality disorder. Cluster B includes dramatic, impulsive, and erratic features that include narcissistic, borderline, antisocial, and histrionic personality disorder. Cluster C includes anxious and fearful features, including obsessive compulsive personality disorder, dependent personality disorder, and avoidant personality disorder. Coming towards avoidant personality disorder. An avoidant personality disorder is shy and timid. He's an inhibited person. He lives a socially withdrawn life. He's hypersensitive to any rejection. He's afraid to speak up in public or to make requests to others. They have a feeling of inadequacy, uncertainty, and develop inferiority complex. And they have a great desire for companionship, but they need unusually strong guarantee of uncritical acceptance. Coming towards the diagnostic criteria, the DSM-5 states a pervasive pattern of social inhibition, feeling of inadequacy, hyperactivity to negative evaluation, beginning by early childhood and present in variety of contexts, characterized by at least 4 of the criteria, which includes avoids occupational activities that involve significant social contact due to fear of disapproval or rejection, unwilling to deal with people unless sure of being liked, restrained within an intimate relationship due to fear of being shamed or ridiculed, preoccupied with being criticized or rejected in a social situation, inhibited in a new social situation because of feeling of inadequacy, view themselves as socially inept, personally unappealing or inferior to others, unusually reluctant to take risks or engage in a new activity because they may prove embarrassing. Out of these, at least 4 should be fulfilled to fulfill the criteria. The coarse and progressive. Many people are able to function in a protective environment. They are even able to marry and have children. However, if the support system fails, they are subjected to depression, anxiety, and anger. Patients give history of social phobia or incur social phobia in the course of their illness. The impairment is usually severe, including occupational and social difficulties. The differential diagnosis can be a social phobia. It is very difficult to distinguish between these two. In social phobia, specific situation rather than intrapersonal contacts are avoided. In panic disorder with agoraphobia, it manifests avoidance usually after the onset of panic attack. Now differentiating it from other personality disorder, In schizotypal and schizoid personality disorder, the social isolation of avoidant personality disorder is accompanied by the desire for social relations, which is not observed in schizoid or schizotypal personality disorder. Differentiating it with paranoid personality disorder, it includes a guarded attitude, preoccupation with hidden meaning, and conspiratory explanation of benign events. While in dependent personality disorder, it is focused on being taken care of rather than on the fear of negative evaluation. The treatment can be psychotherapy as well as pharmacotherapy. Psychotherapy depends on solidifying an alliance with patient. As trust develops, the therapist must convey an accepting attitude towards the patient's fear, like his fear of rejection. Eventually encourage the patient to move out into the world to take what are perceived as greater risk of humiliation and rejection and failure by the patient. However, you need to be careful as failure can reinforce a patient's already poor self-esteem. Group therapy may help patients understand how their sensitivity to rejection are affecting them as well as others. Assertiveness training is a form of behavioral therapy that may teach patients to express their need openly and to enlarge the self-esteem. Pharmacotherapy can also be helpful in avoidant personality disorder as it helps to manage the anxiety and the depression associated with it. Example, beta-adrenergic receptor agonists such as atenolol is used to manage the autonomic nervous system hyperactivity. Serotonin agents may help Serotonergic agents may help rejection sensitivity. Theoretically, dopaminergic drugs might give rise to novelty-seeking behavior. However, the patient must be psychologically prepared for these new experiences. Coming towards the obsessive compulsive personality disorder, the clinical features seen are they are obsessed with orderliness, perfectionism, rules, lists, and orders, and achievement of perfection. They lack flexibility, are intolerant, and have limited interpersonal skills. They are formal and serious and often lack a sense of humor. They are inflexible. They fear making mistakes, therefore, they're indecisive and ruminant about making a decision. They are unable to compromise in any situation. They are rigid with values and morality, hence trouble. Epidemiology is DSM reports an estimate prevalence ranging from 2 to 8% for the general population and 3 to 10% for psychiatric outpatients. It is most commonly seen in men than in women and is diagnosed most commonly in the oldest sibling. Patient may have a background characterized by a harsh display. Fruit hypnotized that the disorder is associated with difficulty in the inner stage of psychosexual development around the age of 2 years. But the study have failed to any study have failed to validate this theory. Coming towards the diagnostic criteria, the DSM-5 states a pervasive pattern of preoccupation with orderliness, perfectionism, and control, with no room for flexibility, beginning by early childhood, present in variety of contexts, characterized by at least 4 of these criteria. That is, preoccupation with details, rules, lists, or schedules to the extent that major part of the activity is lost. Show perfectionism that interfere with task completion, that is, they're unable to complete a project because of their own strict standards which are not met. Is excessively devoted to work and productivity to the exclusion of leisure activities and friendship. Is over conscientious, scrupulous, and inflexible about matters of morality, ethnicity, or value that is not accountable for by culture or any religious identification, is unable to discard worn out, worthless objects even when they have no sentimental value, is reluctant to delegate tasks or to work with others unless they submit to exactly what his or her way of doing things are, adopt a miserably spending style towards both self and others. Money is viewed as something to be hoarded for future catastrophes. They show rigidity and stubbornness. Out of these 8, at least 4 should be present to diagnose obsessive compulsive personality disorder. The course of this disorder is variable and unpredictable. Person may develop obsession or compulsion in the course of this disorder. Some adolescents with OCPD may evolve into warm and loving adults. However, it can also be a harbinger of schizophrenia. Late onset major depressive disorder is commonly seen with this. Person with OCPD may flourish in position demanding deductive or detailed work, but they are vulnerable to unacceptable change and their personal lives may remain barren. The complication seen is there is distress and difficulty when confronted with new situations that require flexibility or for the patient to compromise in a situation. The impairment is severe, including the occupational and social difficulties. Coming towards the difference between obsessive compulsive disorder and obsessive compulsion personality disorder. They may coexist together. OCD is defined by presence of true obsession or compulsion, while OCPD, the behavior are not directed by thoughts that are we are unable to control or irrational behavior that repeat over and over again or often with no apparent aim. In OCD, it is the ego dystonic, while OCPD is ego symptonic. Symptoms of OCD tend to fluctuate in association with underlying anxiety. In OCPD, the behavior tend to be persistent and unchanging over a long term. OCD often seek professional help to overcome the irrational nature of their behavior and the persistent state of anxiety they live under. While in OCPD, usually do not seek treatment and help because they do not see anything they are doing is particularly abnormal or irrational. Now, differentiating it from other personality disorders, in schizoid personality disorder, lack of capacity for intimacy and social isolation, secondary to emotional detachment, as opposed to devotion to work and discomfort with emotion. In antisocial personality disorder, material goals in antisocial behavior and criminality, as opposed to the hypermorality of an obsessive personality. In avoidant personality disorder, isolation due to fear of disapproval or rejection or feeling of inadequacy. In OCPD, isolation results from giving priority to work and productivity rather than relationships. The treatment can be psychotherapy as well as pharmacotherapy. In psychotherapy, unlike patients with other personality disorder, those with OCPD are often aware of the suffering and they may seek treatment. Group therapy and behavioral therapy can be used. Treatment is often long and complex, and countertransferal problems can also occur. Preventing the completion of their habitual behavior raises the patient's anxiety and leaves them susceptible to learning a new coping strategy. Pharmacotherapy, clonazepam, a benzodiazepine with anticonvulsant use, has reduced symptoms in patients with severe obsessive compulsive disorder. Coming towards the last personality of cluster C personality is dependent personality disorder. The features seen in this is that the patient lacks self-confidence. They get others to assume responsibility for major areas of the relationship, distorted by the need to be attached to another person. They have extreme intense discomfort and helplessness feeling when being left alone for a longer period of time. They have a dependent and a submissive behavior. They have difficulty making decisions without an excessive amount of advice and reassurance from someone else. Extensive efforts to obtain nurturance and support from others. Their pessimism, self-doubt, and fears of expressing sexual and aggressive feelings. Coming towards the epidemiology, DSM-5 reports an estimate prevalence ranging from 0.6% for the general population. 2.5% of all personality disorders are falling into this category. It is commonly seen in young children than in older ones. Person with chronic physical illness in childhood may be more sustainable to this disorder. Coming towards the diagnostic criteria, according to DSM-5, an excessive, pervasive need to be taken care of, submissive, clinging, needy behavior due to the fear of abandonment, beginning by early childhood and present in variety of contexts, is characterized by at least 5 of these criteria. That includes having difficulty making everyday decisions without an excessive amount of advice or reassurance from others, need others to assume responsibility for most major areas of his or her life, has difficulty expressing disagreement with others because of fear of loss of support or approval, has difficulty initiating projects or doing things on his own, goes to excessive length to obtain nurturance and support from others to the point of volunteering to do things that are unpleasant, feeling uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself, urgently seeks another relationship as a source of care and support when a close relationship ends, is unrealistically preoccupied with fears of being left to be taken care of himself or herself. Out of these, at least 5 should be present to diagnose it as personality disorder. Course and prognosis. Little is known about the course of dependent personality disorder. Occupational functioning tends to be impaired because person cannot act independently without a close supervision. Social relationships are limited to those on whom they can depend. They suffer physical or mental abuse because they cannot assert themselves. Risk of major depressive disorder is seen if they lose the person on whom they depend. With treatment, however, the prognosis is favorable. Comorbidity, they have increased risk of major depressive disorder, anxiety disorder, and adjustment disorder. The impairment is mild, includes interpersonal relationships and occupational functional if inadequacy is required, if independency is required. Coming towards the differential diagnosis, dependent personality disorder can be distinguished from a mood anxiety disorder and general medical condition, as these dependency behaviors would be expected to stop once the underlying illness resolves. However, they will not stop in this personality, dependent personality disorder. Differentiating it from other personality disorders, in borderline personality disorder, usually have a strong fear of being abandoned, but will tend to react with feelings of rage and emotional emptiness and demand as opposed to the increasing abstinence, appeasements. Submissiveness is seen with the dependent personality disorder. In histrionic personality disorder, they tend to gain attention from others to dramatic or flamboyant behavior, as opposed to people with dependent personality disorder who will be more self-efficacious and docile. While in avoidant personality disorder, social isolation because of fear of negative evaluation as opposed to clinging or submissive behavior of a dependent personality. Coming towards the treatment, we can use psychotherapy as well as pharmacotherapy. Psychotherapy, insight-oriented therapies enable the patient to understand the antecedents of their behavior, and the patient can become more independent, assertive, and self-reliant. Behavioral therapy, assertive training, family therapy, and group therapy can be used. In pharmacotherapy, it can uh, it can be used to deal with specific symptoms such as the anxiety and depression, which is associated with this personality disorder. Patients who experience panic or who have high level of separation anxiety may be helped by imipramine. Benzodiazepines and serotonin agents can be used. This gets me to the end of my discussion. Thank you. No, no.